Dr. Akwe from Harvard. She needs no introduction, really, but just because I have to do it, she was here the last time. So, as we all know, Dr. Akwe does run a very, very tight ship for medical students, which I am very, very pleased to and privileged to be working with one of them, amazing person. So, as we all know, Dr. Akwe is interventional gastroenterologist and the director of global health programs in gastroenterology at MGH, and she's also an associate professor of medicine at Harvard. So please welcome Dr. Akwe, and we are going to be continuing GI Part 2 this month. Thank you. Over to you, Dr. Akwe.
Thank you, thank you, thank you. So once again, I'd like to start off by saying just a big, big thank you to AORTIC for providing this, this wonderful platform where we could share knowledge and hopefully connect, collaborate, and establish future partnerships. I'd like to thank our speakers, who I know would be phenomenal. Right now, we have one speaker who's on. The others are having slight challenges connecting. So hopefully they are able to join, but whatever the case is, each speaker individually is an absolute rock star. So I think in terms of the program today, we'll start, the order is a little bit different because we're just going to go based on who's here. And then if the other speakers are not able to join, it's not a problem. Each speaker is very much capable of actually addressing any question that you might have. And so we'll make the most of the 1 hour. So I'll introduce our first speaker. He's slotted as second, but we'll start with him. So our first speaker is Dr. Mandeep Sawhney, who is a friend, mentor, and he was one of my trainers. So I would call him the king of endoscopic ultrasound. He would say, if you look hard enough, you'll see something. But I am truly, truly honored for him to have accepted to present here today, and actually just honored for all the speakers, for all of you accepting to speak on an international platform. Takes a lot of time for preparation. So just a personal note of thanks and just a gigantic thank you from AOTIC to you. So Dr. Sawhney is an associate professor of medicine at Harvard Medical School, and he's a director of Advanced Endoscopy at Beth Israel Deaconess Medical Center in Boston, Massachusetts. So he will be speaking about the role of endoscopic ultrasound in the staging and management of esophageal cancer. And I know across the African continent, there's probably just a handful of countries that have EUS, but EUS plays a significant role when it comes to esophageal cancer. So he'll go through that with us. And if our other speakers join, I'll introduce them and then we'll continue the conversation. If they don't join, that's perfectly okay. We could still ask Dr. Sawhney some of the questions we have in general about esophageal cancer. And we chose this month because it's Esophageal Cancer Awareness Month. And it's just an important topic. As most of us know, one of the highest rates of esophageal cancer is actually in Malawi. And so this is truly, truly an important topic for all of us. So Dr. Sawhney, once again, big, big thank you. And over to you, please.
Thank you, Akwe. Let me see if I can share my screen. Are you able to see the slides?
Yes, it's coming on.
Terrific.
Yes.
There you go. So thank you very much. It's a huge honor to be asked to present to this group. And I've been asked to talk about esophageal cancer, the role of EUS for staging, and placement of esophageal stents. These are my disclosures, which are not relevant to this topic. So let's start by looking at the principles of esophageal cancer staging, because if you understand these, then it's very easy to understand the role of EUS in cancer staging. So if the esophageal cancer is confined to the mucosal layer, that's a T1A cancer. Once the cancer extends into the submucosa, it becomes a T1B cancer. Cancers that go to the muscularis propria are T2. Once they go through the muscularis propria into the surrounding adventitia, that's a T3 cancer. If the tumor invades the pleura, the pericardium, it's a T4A. And then if the tumor invades a major adjacent structure like the aorta or the trachea, it's a T4B cancer. And the reason why accurate esophageal staging is so critical is because that's what determines what the optimal treatment for that cancer is going to be. So if the cancer is limited to the mucosa, then endoscopic resection of that cancer is the treatment of choice. On the other hand, if the cancer extends into the submucosa or the muscularis propria, then the patient needs surgery. If the tumor goes beyond the muscularis propria through the esophageal wall into the surrounding adventitia or the pleura or the pericardium, then surgery alone is insufficient. And so those patients should be treated with neoadjuvant chemoradiation with the idea of downstaging the tumor and then doing surgery. And then finally, if the tumor involves a major adjacent structure like the aorta or the trachea, then unfortunately those patients are not curative and those patients are treated with chemoradiation. So you can see how accurately staging an esophageal cancer is critical in deciding what the next steps are. And similarly, with regard to lymph nodes, if there are no lymph nodes, then surgery is possible. And then once patient has lymph nodes, then surgery alone is not recommended. The current guidelines suggest that those patients should all get neoadjuvant treatment, the tumor be downstaged, and then be reconsidered for surgery. So endoscopic ultrasound is a very powerful, a very accurate way of staging esophageal cancer. You can see this is an echo endoscope. This has a radial ultrasound tip at the end of it. This scope is passed through the mouth into the esophagus, and then we're using the ultrasound to look through the wall of the esophagus into the surrounding structures. And when you do ultrasound of the esophageal wall, it appears as these alternating light and dark bands. So the first light band is the mucosal layer of the esophagus. The second dark band is the deep mucosa. Then the third light band is the submucosa, followed by the muscularis propria, and then the adventitia. And so you can see this tumor right here has gone through the mucosa, the submucosa, and it's actually invading the muscularis propria and just beyond that. So by endoscopic ultrasound, this would be staged as a T3 type of esophageal cancer. So let's start with early esophageal cancers and the critical decision point here. And so this is a patient with Barrett's esophagus. You can see this pink tongue of Barrett's. And while this patient was undergoing an upper endoscopy for surveillance of Barrett's esophagus, we noticed this nodule in the esophagus. So this is clearly an early esophageal cancer. And so the critical question here is this cancer over here limited to the mucosa? In other words, is it a T1A cancer and endoscopic resection would be sufficient? Or has this tumor invaded into the submucosa? In other words, is it a T1B cancer where endoscopic excision wouldn't be enough? This patient would need surgery. And so the first question is, can EUS help us make this distinction between a T1A cancer and a T1B cancer? And the answer, unfortunately, is no. If you look at the ASGE guidelines, they recommend against the routine use of endoscopic ultrasound to differentiate mucosal versus submucosal disease. So if you have a small nodule and you do EUS, EUS is very inaccurate in telling you whether this cancer extends to the submucosa or not. The sensitivity of EUS is only 41%. The overall accuracy is only 75%. So for these small nodules, these very early esophageal cancers, we should not use EUS. And what we should do is resection and let the pathologist tell us what the actual stage is. So the current recommendations are that if you have a small nodule, do an endoscopic mucosal resection. This is an example of how we would do it with a band. You apply a band to this lesion, create a pseudopolyp, and then you would resect the lesion underneath the band, send the whole tissue to pathology, and then the pathologist tells you the stage of the lesion. So that's the preferred way of staging an early cancer. Now, not all is lost in this area. There are some newer techniques that might allow us with endoscopic ultrasound to differentiate mucosal versus submucosal invasion. This is a study from China, and what these investigators did was they injected saline into the submucosa, thereby greatly expanding the submucosa over here. So now that the submucosa is greatly expanded and more clearly delineated, you can see this tumor right here, which is this hypoechoic area, is limited to the mucosal layer. Whereas if you look at this lower image, you can see that this tumor now extends into the submucosal layer. And you can make this distinction more clearly because the submucosa is greatly expanded by a submucosal injection. And what these investigators showed is that you can improve the accuracy of EUS for picking up submucosal invasion to almost 94% with this technique. And this is certainly something that we will be seeing more of. So what about other esophageal cancers, T2, T3, and T4? And again, here, the distinction is critical. If the patient has a T4 cancer, a T2 cancer, then surgery is the optimal treatment. If this is a T3 or a T4 cancer, in other words, the tumor has gone beyond the muscularis propria and extends into the adventitia, then these patients should undergo neoadjuvant therapy before surgery. And then finally, if the tumor involves the aorta or a major structure, then unfortunately those patients do not benefit from surgery and should undergo definitive chemoradiation. So how good is EUS in helping us differentiate these? These are results of a meta-analysis, and what they show is that EUS is actually quite good for a T4 lesion and a T3 lesion with accuracies over 90%. EUS, unfortunately, is not very accurate for a T2 lesion. The accuracy is not only low, but in studies it's been quite variable. And here there are problems both with over and understaging. In other words, sometimes a T1 cancer can be overstaged as a T2 and vice versa. So anytime you make a diagnosis of a T2 cancer on EUS, you need to recognize that that may be with low accuracy. The other point I want to make here is that even though EUS is far from perfect, it is much better than a CT scan or an MRI for T staging, and it's currently our best modality for T staging esophageal cancers. What about lymph nodes? And the story is somewhat similar over here. If you look at EUS alone, the accuracy for lymph node staging is somewhere between 70 and 85%. If you add fine needle aspiration, in other words, if you find a lymph node with EUS and then you biopsy that lymph node with EUS guidance, you can increase the specificity of your test and the overall accuracy of almost 90%. And even though, again, EUS is far from ideal, it is much better than a CAT scan that has an accuracy of only 63% for lymph nodes and a CT PET, which is only slightly better. So this is an example of a patient with a large esophageal mass who's undergoing EUS staging, and a radial echo endoscope is gently inserted through the esophagus, and then we gently pass the scope through this area, and then the ultrasound sits right here, and then we're imaging through this tumor into the wall of the esophagus. So if you look at this dark layer over here, this is the muscularis propria, and you can see this tumor, which is all here, has gone through the muscularis propria, and over here you can see the tumor has actually invaded into the adventitia. So this is a T3 lesion. When the scope was gently withdrawn, unfortunately, you can see there's an enlarged paraesophageal lymph node over here that was also present. So this patient, based on EUS, would be staged as a T3 N1 type of cancer. So, based on what I told you, the American Thoracic Society recommends that all patients with locally advanced esophageal cancer should undergo an upper endoscopy with endoscopic ultrasound and fine needle aspiration, in addition to a CAT scan of a chest and the abdomen and a CT PET, because EUS remains our best test for staging the tumor and lymph nodes in patients with esophageal cancer. So moving on to the next topic that I was given, which is esophageal stents. This is a 75-year-old that we saw who had an esophageal cancer. Based on the stage, it was determined that this patient should undergo neoadjuvant chemoradiation and then reassessed to see whether she would be a surgical candidate or not. Unfortunately, when a follow-up scan was done for this patient, liver metastases were found, and so the patient was no longer a surgical candidate. Her disease quickly progressed, and when she presented to us, she had severe dysphagia. She was barely able to swallow her saliva, and this is an endoscopic view of the esophagus. You can barely see the esophageal lumen over here. It's almost completely obstructed by the esophageal cancer. So these are the AGA guidelines for management of patients with esophageal cancer who present with obstruction or dysphagia. So these guidelines suggest that patients who are not surgical candidates, patients who have advanced disease, just like the one I showed you, this patient had metastatic disease, an esophageal stent is the preferred treatment modality for such patients. On the other hand, patients who are potential surgical candidates, or those who are undergoing chemoradiation, the current guidelines suggest that we not routinely place stents without a very careful multidisciplinary review. The reason for this is that some patients who are undergoing chemoradiation may have a substantial shrinkage of their tumor such that a stent would migrate. There is some morbidity and mortality associated with stents in patients undergoing chemoradiation. And then finally, there's some data to suggest that the placement of a stent may reduce the likelihood of an R0 or a complete resection. And so patients who are undergoing neoadjuvant chemoradiation, with the idea that in the future we'll be able to downstage their disease and then consider an operation, we typically don't offer them a stent unless we put these patients through a very careful multidisciplinary review. For those patients who are potential surgical candidates and who have malnutrition, at least at our center, we would consider a nasogastric tube or a PEG tube. Now, these are not ideal. Patients don't tolerate nasogastric tubes well. PEGs have their own problem. There's a small risk of abdominal wall tumor seeding with these gastrostomy tubes. Sometimes the surgeons tell us that it becomes difficult to make a gastric conduit in patients who've had PEGs. So this is not an ideal situation, but we typically don't go straight to an esophageal stent in these patients. The guidelines suggest that if you are going to place an esophageal stent, we should place a fully covered or a partially covered stent, and we should avoid uncovered stents because these patients have a very high likelihood of tumor ingrowth and stent obstruction. So these are three commonly commercially available stents that are available to us in Boston. And they all basically have the same design and the principle. They look like cylinders that are made of a wire mesh. These stents come in very tightly packed on this introducer. And then slowly, as you pull back the sheet that is holding this stent in place, you can see the stents slowly start deploying. And then once you fully pull the sheet back, the entire stent is deployed in the esophagus. And so this is what we did for that patient that I showed you. So you can see this is all done under fluoroscopy. So this is the endoscope, and the endoscope cannot be advanced beyond this layer because there's an obstructing esophageal cancer. Very gently under both endoscopic and fluoroscopic view, you pass a wire through the obstruction all the way into the stomach. And then very gently over the wire, you pass the stent introducer, and you can see there are marks on the stent that tell you where the stent will deploy. and then slowly you pull the sheath back that is holding the stent against the introducer, and you can see the stent deploys in the esophagus. And very quickly, and this is an endoscopic view of what it looks like through the stent, and very quickly it expands. These are called self-expanding metal stents, and very quickly it'll reconstitute the lumen. It takes about 24 hours for the stent to fully expand, but once you put a stent in, patients can typically start drinking water and eating soft foods fairly early. So stents work pretty well when patients are carefully selected. We're able to technically achieve success in almost 100% of patients. Clinical success defined by patients' ability to consume soft, solid foods is also very good, almost 90%. The median patency of stents in most studies is between 6 and 10 months, on average about 8 months. But these stents aren't without a downside. The most common complication we see from these stents is pain and reflux. Most of these patients can be managed with high doses of acid-suppressing medications. There's a risk that the stents may migrate. The risk is about 4 to 13%. We've gotten better at this, so we're now closer to 4 or 5% because we know how to fix these stents using clips or sutures onto the esophagus, and that prevents migration. There's a risk of fistula formation if the stents are left in long enough. And mercifully, very, very rarely, there's perforation or bleeding. This happens infrequently, but when this happens, this can sometimes be fatal. So we really do need to talk to our patients about this. So just to summarize, that EUS staging is recommended for all our patients with locally advanced esophageal cancer. It is our best modality. It's better than a CAT scan and an MRI for T and N staging of esophageal cancers. However, EUS is not useful for very early esophageal cancers. The current guidelines are to do an endoscopic mucosal resection, send the whole piece to the pathologist, and let the pathologist stage the tumor. And certainly, if your patient already has metastatic disease, then there's no advantage in doing T or N staging with the EUS. Esophageal stents are very effective for palliation of dysphagia. The ideal candidate for an esophageal stent is someone who's not a surgical candidate. For patients undergoing neoadjuvant therapy with the idea that they may have an operation in the future, we don't routinely put stents, only after a very careful multidisciplinary review that typically involves the surgeon. Stents are associated with high technical and clinical success, and complications can occur, including very rarely fatal complications. Thank you very much for your attention.
Thank you so, so much, Dr. Sani. We'll actually hold questions. So thank you to everyone who's sending in their questions. Feel free to send them to me privately. You can post them in the group chat. I think the chat is enabled, or you can put them in the Q&A. But I'm more than happy to ask the questions on your behalf. Our next speaker is here. Dr. Madhkur, I'm trying to find him. I know he's here because he texted. Oh, there he is. Yeah. Perfect. So we'll hold our questions, everyone, but let's move on to our next speaker, Dr. Ahmed Madhkur, who is very well known, especially his expertise in third space, one of the leading interventional GIs across the African continent and globally, really, who brought third space out, say, to Egypt. He is an interventional gastroenterologist at Helwan University in Cairo. He is a phenomenal teacher, hosts a lot of our ESD courses across the African continent, not only for those in the continent, but those across geographical boundaries from the continent. So he is going to focus on precancerous lesions. And so these are obviously lesions before we reach the stage of cancer. How do we identify them? How do we resect them? Are they resectable? And then if our third speaker is here, we'll move on to our third speaker, who's a cardiothoracic surgeon. If not, we'll get into the questions. So once again, just another big, big thank you to Dr. Madhkur as well, because I know how busy he is as well. He wasn't here for the early one, but I wanted to acknowledge your presence and gratitude, not only from me personally, but from AORTIC for your time and dedication to education. So the stage is yours, and you should be able to share your slides. So over to you.
Yeah, thank you, Akwi. It's a great pleasure always to join the activity organized by you and your team, and I'm very happy to be part of this. Uh, I'm not sure how can I share my screen if I can have the permission for this.
Secretariat, does he have permission? It should be at the bottom. Does the share button light up for you? Are you able to share at the bottom? Do you have the share button on your screen?
Yes, it's okay.
Okay, there you go.
So you can see the screen now, the whole screen.
Yes, if you change it to presenter mode.
Okay, now it's okay.
It's perfect. It's perfect.
Okay, so Akwi, thank you. It's very well organized to see the different option for treatment and the option of diagnosis as we see in the first lectures. So I think we have to say one more word here. It's not only the pre-malignant lesion, but also the malignant lesion, because we still can be able to resect some malignant esophageal lesion and be a curative R0, and we don't need further treatment if we have some early detection for these lesions. If you look here, usually we keep in mind the mucosal lesion. This is the most common and the most familiar to see, but still some mucosal lesion may have some malignant potentiality. It's rare, but it's still there, and we should keep in mind and know when we can deal with endoscopically and don't refer for surgery or more invasive treatment. The mucosal lesion mainly is either squamous cell or esophagus. I'm not sure about the cohort and the demographic and the prevalence of these lesions in Africa. But in Egypt, we have some more parrot. We have a very low rate of squamous cell cancers, either for in early detection or even in advanced, we don't see as much as we see the parrot. Usually, to have a better workup for each patient, we have first to detect the lesion. If we miss detecting the lesion, we couldn't proceed for other option, how to assess and how to decide if we send for surgery or do endoscopic resection. So the detection is the most important. If we don't detect, we don't manage. After we detect the lesion and do proper assessment through endoscope or through other modality, we go for the decision. Should we try to resect this lesion, or we have to send for surgery, or just for palliative chemoradiography? And if we are going to resect, which modality we use for resection? We just place a snare, or we have to do like a band EMR or go for ESD? We have to know how to answer these questions, how to do a good detection, how to do a good assessment. Then we decide how to deal with this lesion. How to resect the lesion? It can be endoscopic or surgery or sometimes combined, but it should be technically feasible in our center. We can do, and it should give a complete resection. So we don't go for endoscopic resection for some lesion where we are not sure we can have like an R0 complete resection for this lesion. If you look here, this is a picture of a mucosal lesion. It's in the upper esophagus and it may be missed. Some may think it's some like erosions. That's why we should do the examination using the PLI or narrowband or advanced chromo endoscopic examination. If you look here for the comparison between the white light and the narrowband for detection of the lesion, you can see here there is a big gap between 55% as a sensitivity for white light, which reach up 97% when we use a narrowband. Even here, if you look, this is like a hypopharyngeal lesion. We can still detect on the arytenoid cartilage when we do the upper endoscopy. So it's very important to do a careful examination using narrowband so we don't miss this lesion. And that why come the Japanese recommendation how to do examination for those patients. First, we have to examine the esophagus using the narrowband image, the whole esophagus. When we move to the stomach, we switch to white light, and then when we see any suspicious lesion, we switch back to narrowband to evaluate. After we finish the examination, when we withdraw the endoscope again, we switch back in the upper esophagus to the narrowband again to examine any missed lesion during intubation, because very high lesion may be missed during intubation, and also to examine the hypopharynx. And there was a very nice video published a few months ago in GIE how to do like an oral examination using the upper endoscope when you're doing a scope for the patient. If we go for the first type of the mucosal lesion, which is squamous cell cancer, we have here the most old, the most eminent, the most strong guidelines, which is the Japanese guidelines who invent this type of endoscopic resection. And if you look here, usually we decide to do endoscopic resection or not, depending on the lymph node mets. If we have a risk of lymph node mets, even if we resect the lesion, this is not curative, so we avoid resection. But the Japanese here add one more item, is the length and the circumference. So if we think this lesion is a superficial mucosal lesion, we look if it's a circumferential or not. If it's not circumferential, we can go for ESD, whatever the size of the lesion. If the lesion is circumferential, we see if it's more than 5 centimeters, they prefer to send this patient for surgery. And if it's lower than 5 centimeters, we can do endoscopic resection. Why they do this decision? Because of the structure. Usually when we have a circumferential ESD, we have usually stricture in 100% of cases. If we have circumferential, we have 100% of cases, we have stricture. So if this lesion is longer than 5 centimeters, with stricture, it's usually a very complex stricture. It may need dilatation more than 10 times, 10 to 15 times. And this is not the minimally invasive. In those patients, may be minimally invasive to send for surgery. Again, this is the Japanese guidelines, maybe Korean and the Chinese guidelines is a little bit different. And if we go for a suspicious of deep mucosal invasion or superficial submucosal invasion, we go again for the circumference. If it's circumferential, we send it totally for surgery. If it's not circumferential, we resect. And according to the pathology, we decide if this is curative or zero or we need a further treatment. So to summarize, if it's a superficial, we go for resection if it's not circumferential. If it's a superficial and circumferential, we look for the length. Lower than 5 centimeters, we go for resection. Longer than 5 centimeters, we go for surgery. If it's suspicious to be a deep, not very deep, but superficial submucosa or deep mucosa, we look. If it's a circumferential, we send for surgery. If it's not circumferential, we do resection and then have the final decision after having the pathology. And the pathology will comment on the lymphovascular invasion and the depth of invasion. And according to those items, we decide to send the patient for more chemoradiotherapy or surgery, or we say it's a curative and just going for follow-up. Then comes the questions, how to expect the depth of invasion, if it's a superficial mucosal or deep mucosal or submucosal. At this point, we need like a magnification endoscopy, and there is some classification called the ENO classification. We depend on what called intrapapillary capillary loops. It's as you can see here, this is a nice video how to evaluate this case. You can see here with this zoom endoscopy, you can examine the capillary of the lesion. This is a totally different learning experience. You can be able to do ESD, but someone else do this examination to do the assessment, and then sometime low-dose iodine can work to delineate the lesion. I don't know if see if it's work. Let's see, because this is important to see the picture of logos iodine. I think we can see here. I'm sorry if the connection is not so good. Anyway, logos iodine can help us to delineate and mark the lesion and go for endoscopic resection. I'm sorry, maybe you have some problem. I hope it works now. Okay, so if you look here, we talk that the Japanese guidelines different from Chinese guidelines. This was one of the cases I attended during my training in China. It's not my case. They do a circumferential ESD for 14 centimeter esophageal squamous cell early cancer. It's still feasible if we do what called ESTD or endoscopic submucosal tunnel dissection, and a lot of research, a lot of hot topics, a lot of modality, how to avoid stricture in those patients. Before we move to the adenocarcinoma and the Barrett adenocarcinoma, this was a very nice study, came from Japan, and they evaluate the outcome for those patients who have expectation to be a deep mucosal or superficial submucosal invasion before resection. So those is the high risk group, as we mentioned. If they are circumferential, they didn't do ESD, but then they do ESD for those non-circumferential high suspicious lesion. And then they started to see the results. So they found that around 71% of those patients actually didn't need a further treatment. Didn't have lymphovascular invasion, they didn't have a deep invasion, and they follow up, and only one patient have a recurrent lymph nodes, and there was no mortality from the squamous cell cancer. And the other group of patients, they receive further treatment in form of chemoradiotherapy, and all of them follow up without any recurrence or disease-related mortality. That allow to expand a little bit the role of endoscopy in those patients. It may need further study, and it need a very good, precise histological assessment to highlight the risk factors, because if we have any lymphovascular invasion, no rule, we have moved to for other treatment. Or if it's only the depth of invasion, we can see here around only one patient who have a recurrent lymph nodes. The second mucosal pre-malignant lesion is a Barrett. You know here, this is Barrett esophagus. It's a very famous, but it's come from the Professor Norman Barrett, who was in 19 of last century. And Barrett, it means an esophageal metaplasia for above the GE junction. It should have been around at least 1 centimeter above GE junction. And it's a very cancerous condition because it may develop to a intramucosal carcinoma and then invasive cancer, and before high-grade or low-grade dysplasia. This is the normal esophagus, and this is how Barrett can be seen, and it should be confirmed by biopsy to confirm intestinal metaplasia. When we started to evaluate a patient who suspected to have a Barrett, we should keep in mind 3 landmarks. So we are sure this is actually a Barrett. These landmarks is the diaphragmatic impression and the GE junction and the squamous columnar junction. And as we know, we can have a Barrett over hiatus hernia, and we can have a hiatus hernia alone, and we can have a Barrett alone. This is very important because sometimes if we have the biopsy below the Z line, and we will have a gastric mucosa, it may be conflicted if the pathologist is not oriented to comment on the metaplasia. So we should keep in mind these 3 landmarks when we assess patient with Barrett. The second thing, how to describe this Barrett. There is what called Bragg classification. The Bragg classification depends on 2 items we should comment on: the M and the C. the maximum extent and the circumference. If we look here, this is a parrot. This is like the maximum extent is here. So this is the M, the highest point that the parrot reach. And this is the circumference. So here, if we look here, here is a circumference around 2 centimeter, and this is the maximum extent is 4 centimeter. So we comment, say it's a C2M4, and we should comment like this on each parrot esophagus we diagnose. How to deal with this parrot esophagus? We wanted to summarize this. What called like a sum rule. If we have any nodularity, we should resect. Any visible lesion should be resected either by band EMR or by ESD according to the degree of dysplasia or suspicious of invasion. If it's not a visible lesion, we can go for radiofrequency ablation or cryoablation if refractory. In my country, in Egypt, we don't have a radiofrequency ablation and don't have cryoablation. Maybe this is the situation in many centers in Africa. So actually what we did, we resect all visible lesion. And non-visible lesion, we check the dysplasia. If we have a high-grade dysplasia or suspicious of intramucosal carcinoma, we do ESD. If it's a low-grade dysplasia for non-nodular, no, just a flat lesion, we go for hybrid ABC or give treatment and follow up. So we use hybrid ABC for low-grade dysplasia, non-nodular, and we go for ESD for high-grade dysplasia. And for any nodular lesion, we go for endoscopic resection. And you can see this is not a nodular lesion, but it have a high-grade dysplasia. So we go for ESD. And this is how the lesion looks after resection, and it was intramucosal carcinoma. And actually, we still can do some circumferential ESD for those lesions. Even we may have some stricture after we did, but if it's lower than 5 centimeter, we follow the Japanese guidelines in this. If it's lower than 5 centimeter, we'll go for resection. And here, to assess curability, this lesion is curable or not, we depend on the deep invasion as a gastric cancer. So we say in the esophagus, we don't need the lesion to come deep in the submucosa at all and be in the superficial mucosa. But when we deal with Barrett, we deal with criteria of curability in gastric cancer. So we still can accept that the lesion extend in the superficial submucosa lower than 500 micron, which is half millimeter. At this time, it's curative. So we deal with as a gastric, not as an esophageal cancer in the term of curability and the R0 resection. And you can see we still can resect those lesions even if they go beyond the Z line, as you see, and circumference. Finally, which is good to mention, is the submucosal lesion. Usually, the submucosal lesion esophagus is very rare. That's the malignant leiomyoma. But we have seen like 2 cases of esophageal GIST and 1 cases of esophageal leiomyosarcoma, which was resected like a leiomyoma and found to be leiomyosarcoma. And this is a nice case. It comes from China, actually. One of my Chinese friends, they have this exophatic GIST. So the lesion is GIST and it has some thoracic extension. So they do like a tunnel, like a stair, as you see, and then they go through thoracoscope and start just to open the esophagus and let the lesion out and they take the lesion out. And this is called endoscopic thoracoscopic cooperated surgery. And this let the patient avoid like a major surgery like esophagectomy. And also there was like a small pulmonary nodule here, like a pleural nodule. So they also resect and then close the esophagus. So the endoscopist just makes the lesion free from inside and they work again from the thorax. And this is one of the interesting cases, how to do like a multidisciplinary approach for those patients. And this is the second type of esophageal submucosal lesion, which may have some malignant potentiality. It's low, but still there, is a granular cell tumor. Usually, it's originated from the third layer. Still, some reports you can resect using EMR or band EMR, but the incidence not to have a complete resection is not low. So usually in those patients, we go for ESD if we want to resect, especially if the lesion is more than 1 centimeter, and we do a tunnel and start to do like a tunnel ESD. Then we open the edges of the mucosal incision. Why we do this? To make sure that we remove the whole lesion and we don't leave some of the lesion in the submucosa. And if you look here, it's usually small lesion. Granular cell tumor is one of the rare tumor of the esophagus. Usually it's in the lower esophagus in 65%. And very rare, it's in the upper esophagus only in 15%. Risk of myths related to the size, no specific specialized guidelines for how to resect and the best way. It can be followed up by EUS if it's lower than 1 centimeter, but if it's more than 2 centimeter, it's better to resect. ESD or modified EMR like CAP assisted EMR is still one of the accepted options to deal with those submucosal lesion in the esophagus. And thank you.
Thank you.
Thank you.
Thank you so much. Let's see. I don't see, and you can stop sharing the slides.
Sure.
Let's see. I don't, Prof. Dr. Russ White, are you on? And if he's not on, why don't we get into questions? Mudcry, for some reason I still see your screen.
Okay, I am trying to do this.
Oh, I see. Okay, no problem. Then I'll start with questions as you're doing that, if that's okay. So I'll do the questions in the chat. So the first question, this is for Dr. Sani. Is EUS useful for pharynx and larynx cancer, laryngeal cancer? Is EUS useful for pharyngeal and laryngeal cancer?
No, I don't think EUS is very useful, just given the anatomy of those structures.
Okay. Then the second question in the chat, I think this is for you too, again, Dr. Sani. How can a migrated stent be managed? Do all stents need to be sent to the surgeons, or are there any endoscopic options?
So I would say that we manage most of the migrated stents endoscopically. The one good thing about esophageal stents is that they're very large. And when they migrate into the stomach, they'll very often just sit in the stomach and do nothing. So it's very reasonable, especially if you have a patient who has very advanced disease and the stent has migrated into the stomach. You can choose to just leave it in the stomach because the likelihood that it'll go through the pylorus and cause small bowel obstruction is exceedingly low. But very often what we do with these patients is that we'll do an endoscopy, and because these are stents made of wire mesh, they collapse very easily. There's usually a little thread at the upper end of the stent. We're usually able to pull that thread into the endoscope that collapses the upper end of the stent, and we're usually able to pull it out of the esophagus. So I would say that 99% of these stents can either be removed with endoscopy or they can be left alone in the stomach, and almost none of them will need an operation.
Thank you. Then the next question is for you, Madhkur, Dr. Madhkur. So you had shown a slide with the three landmarks. Can you please explain what's the difference between the diaphragmatic impression, the gastroesophageal junction, and the squamocolumnar junction? Can you please explain the difference between those three?
Yes. So the squamous-columnar junction is related to the epithelium. You can see the connection between the esophageal epithelial mucosa and the gastric, which is totally different in the color and textures. And the gastroesophageal junction is the merge of the gastric folds. You can see these gastric folds, and the diaphragmatic impression. You can see it's like an impression. So usually the three in the normal, the three is very close. when you see the gastroesophageal junction, epithelial junction, and the diaphragmatic impression, and the gastroesophageal junction, which is the gastrococcygeal when it started to merge like this. When we have a hiatus hernia, we can see part of this gastroesophageal junction above the diaphragmatic impression. This is the real definition of the hiatus hernia. And still we can have a Barrett esophagus over a hiatus hernia. So we should keep this in mind. One of the mistakes which may happen sometimes when a biopsy is taken from a gastric site, from a hiatus hernia, as if it's separate, and it will come as like a gastric mucosa. And if the pathologist was not minded to comment if there is a metaplasia or not, it may be misdiagnosed as Barrett, while it's actually a gastric mucosa. We just take from the stomach because we take from a hiatus hernia. Okay, so this is important to keep in mind. The same also for achalasia. It's, because the sphincter is something different from the hiatus hernia. So we still can have a patient who have an achalasia, spastic sphincter, and they have a hiatus hernia. They are two different pathology. So if we keep in mind these three landmarks, we can differentiate with a different pathology.
Thank you. There's a question, so I'll go to the chat and then I'll go to the private question. So Dr. Sani, I'll have this for you. I am Mr. Mutai Charles from Kenya, a PhD student. Esophageal cancer can be induced to animal model and it takes long to develop. Are there any pilot studies for this cancer? And I'm not sure if they're referring to pilot studies in animal models, but I'm just reading it as it is.
Yeah, no, I'm not aware of the animal models. The best mucosa to abnormal mucosa to cancer sequence is in patients with Barrett's esophagus. In the early days when we did not have radiofrequency ablation, the standard treatment, for example, for Barrett's with high-grade dysplasia would be to continue to survey the patient and consider surgery only if it turned into cancer. And in those patients, it looks like it almost takes 5 to 7 years from dysplastic Barrett's to turn into cancer. So it's a very similar to a polyp to a cancer sequence that we see in the colon.
Okay, thank you. Dr. Mathkur, there's a question about training. We don't have a lot of training centers in Africa for third space. How do I learn how to do EMR and ESD? It's a very big question. I know you've done whole hour presentations, but maybe in a couple of minutes.
Yes, actually, the right thing is to know when to start to learn this, because you should first do a lot of cases. We have a very good tip control, and you do like some standard resection, deal how to use clipping, hemostasis. Then you started to move a step up. And we have some courses on an animal live sedated beds. This is the best way to start. And we have some experience, and we have around 12% in 2-day courses who attend the 2 days course started to. It's not a very large number, but it's a good number. So between every 10, one started to do. And we do some intensive course, which is 5 days. And this number increased to around 21. So around every 5, one of them start to be able to do ESD in his center after working on animal. And it's totally different to compare EMR with ESD. I think polypectomy and EMR, it's something should be like standard. We have to learn how to do. Then before we started to learn ESD, you couldn't go to start learning ESD before you are doing a lot of polypectomies and doing EMR. So this is the right way to go. And final thing in this point, maybe we couldn't do in some countries, like my country, like 7 years or 8 years ago, we didn't do in ESD. If you couldn't do what you should do, you should know what you shouldn't do. I mean, if I see like a suspicious lesion, which can be T1 cancer, it's better to do ESD. But if I can't do ESD, no problem. But I shouldn't place a snare. I should know what not to do. If I place a snare on a T1 cancer, I do a harm for the patient. If I send this patient for surgery, maybe I overtreat, but I didn't do a mistake. So this is very important, what not to do.
Mhm.
I should learn what not to do, not to cause a harm for the patient.
Thank you. And for those who are interested in the training, Dr. Mathur actually posts on his LinkedIn pages, usually when he has a course. I'll be joining you one of these days. We are running out of time, but with permission, there's 3 questions. I'll ask one of them, and then the other 2, I'll combine them. They're both for Dr. Sani. So the first one, and then we'll have to wrap up because I really want to be respectful of time. So the first question is for Dr. Asani. We have a case diagnosed with SCC of the GEJ and adenocarcinoma who also has severe dysphagia. What is the best option for them? Stent, feeding tube, or neoadjuvant therapy?
So like we said, the ideal thing here would be to stage the patient. So occasionally we will see patients with adenocarcinoma with squamous cell differentiation. So I think you want to stage the patient, and then depending on the stage, if it's a T2 lesion, the patient may benefit from surgery. If the lesion has gone beyond the muscularis propria to the adventitia, then these would be patients who would benefit from neoadjuvant therapy, downstage, and then surgery. And then if your patient already has metastatic disease and has severe dysphagia, then that would be someone we would consider a stent for.
Thank you. And so there's 2 more questions, but I'm going to combine them because I think the response is actually related. So the first question is, which is a preferred EUS to esophageal cancer, linear or radial? Then the second question from someone else is, if there's a need for biopsy, linear is ideal. Many people are drifting away from radial as it doesn't give room for biopsy. I think that was more of a comment. So I'll have you just answer, broadly your comments on linear or radial and the role of each one of them, since they do both have a role.
Yeah, so our practice when we get someone referred for esophageal cancer staging is to repeat a very careful upper endoscopy where we mark all the landmarks, because the surgeon will want to know how high, if there is Barrett's, how high that goes, because that's typically included in the resection, where the tumor starts, where the GE junction is there a hiatal hernia or not. So we first do a careful upper endoscopy. Then the next step is to do a radial EUS, because the radial EUS gives us much better tumor staging or T staging than a linear scope does. So we'll do T staging with a radial scope, and if we happen to detect lymph nodes on the radial EUS, then we'll take the radial EUS out, and then we'll insert a linear EUS of the patient, and then use that linear to sample lymph nodes. Now, if the lymph nodes happen to be behind the tumor, in other words, if your needle has to traverse the tumor to get to the lymph node, then those lymph nodes should not be sampled, because obviously your needle can be contaminated by tumor cells from the primary tumor itself. So our standard is an upper scope followed by a radial scope followed by a linear scope if we see lymph nodes.
Okay,
Is that something you do as well?
Yeah, yep, that's exactly it. Yeah, that's exactly what we do as well. And then the last question, I know we're out of time. This last question is about esophageal stenting. Does it matter if it's in squamous cell versus adenocarcinoma? Does it matter who you stent, or can both types be stented?
Both can certainly be stented. The only thing that I'd remind you is that squamous cell cancers are usually in the upper esophagus, and we really have to be mindful that that tumor is not extending into the trachea, because when you put a self-extending metal stent in the upper esophagus, sometimes you can induce airway compression. So most adenocarcinomas are in the distal esophagus, they're below the carina, and you can very safely put a stent. But if the mass is in the upper esophagus, and most squamous cells are, then you really want to take a careful look at your CAT scan, make sure that the tumor isn't already pushing on the trachea, which you can make worse with a self-expanding metal stent.
Thank you so much. And as we wrap up, before I hand back to our VP, Dr. Abiola, I want to say once again, just a big thank you to our speakers, Dr. Sani and Dr. Madhkur, for their time, their dedication to training and education. This, to my understanding from AOTIC, this is going to be up on YouTube. So if you came in late or you just want to listen to this again, please feel free to watch the AOTIC videos. And then for those who are interested in training, like I said, Dr. Madhkur gives like hour sessions, and he usually posts on his LinkedIn page. So you can find actually both of them on LinkedIn, and you can follow up and see when they have courses that you might be interested in attending. So once again, on a personal note, thank you. And on behalf of AOTIC, thank you. And a big thank you to AOTIC for the opportunity for Massachusetts General Hospital Global GI to partner with you for this past couple of months. It's truly been an honor. So thank you, and thank you to the Secretariat. Dr. Aviola, over to you, and a big
Right.
thank you.
Thank you very much for this wonderful hour. I really appreciate it. I'm trying to be very mindful of your time. So any questions left, you can reach out to the presenters. I believe your email was shared. This presentation is actually on YouTube too. So like I said, ASCO is coming up. We have the AORTIC reception in the Union League Club May 30th. We are going to be sharing the flyers to everyone. I would like you to attend. As at now, our agenda is open. So anything anyone thinks that will be a good thing for us to have in our agenda, I'm open to listening. And if nobody brings anything, just bring your dancing shoes and we are going to dance. All right. And we also have our Best of ASCO Africa coming up in Abuja, July 10th and 11th. And the next series 18 will be holding, like we always do, first Tuesday of every month. And this time we'll hopefully share the calendar invite on everybody's calendar. We apologize for the mix-up for this month. Thank you again for the past 2 months, Dr. Okoye. It was really very nice listening to your team. All right, bye-bye now for everybody. Thank you. Bye-bye.
Thank you. Take care, everyone.
Yeah, bye-bye.